Okay, so my name's Keith Boone. I'm an enterprise architect for Audacious Inquiry and leader of the SANER project that we incepted back in late March. And I'm here to tell you a little bit about the SANER project. So what I'm going to cover in these slides is what is the SANER project, why we need it, what our vision is for it, who's involved in the SANER project, what we've accomplished in the less than 3 months that we've been working on this thing, what are our next steps, and where you can go to learn more. So in terms of what is SANER, SANER is simply an acronym for Situational Awareness for Novel Epidemic Response. And it's really about how we share information about the health system and its ability to respond to emergencies, such as a novel epidemic. The challenge that the SANER project tries to address is the disconnected emergency response infrastructure we have in the US. Right now, hospitals are having to report information about how they're doing, how many beds they have available, ventilators, support, protective equipment, staff, etc., to local, state, and federal agencies, each of which are asking for slightly different variations of data using different formats. They're having to report essentially the same things to the state as they are to either the CDC or FEMA. They have to use different portals, different information systems to handle the reporting, to do the communication. And then at the local and state level, again, these same organizations and agencies don't really have a consistent way of communicating across each other. So that's the challenge that we have, and that basically creates sort of the worst case of if you've got N organizations that need to communicate to each other in a point-to-point fashion, you have N squared numbers of communication links that need to be created, and if you've got N organizations having to report to M agencies, then you have an N times M number of reports that need to be sent back and forth, and that creates huge burdens on a health system that is already under stress due to the fact that you're in the middle of a health emergency. If you want to look at the kinds of things that the health systems are being asked to report, here's an example form, which is building off of a manual process. You can imagine somebody being sent into the ICU and actually counting the number of people who are in ICU beds, or somebody creating a list of how many ventilators they have in the hospital, and somebody else saying, well, we've got X number in use. Running around with clipboards and then turning around and entering this data into spreadsheets and then uploading spreadsheets into portals and then having to send this same information out to multiple different agencies in slightly different formats with slightly different breakdowns. And in this one example form, CDC estimates that the cost to the health system for reporting this, or the hospital that's reporting this, is 25 minutes per response. Okay, and so this response is expected once per day by the National Healthcare Safety Network at CDC. You can imagine in a rapidly emerging sort of situation where there's a tremendous amount of activity going on, you'd like to have more reporting done per day, and a lot of organizations are now reporting 4 times per day. And they're also reporting multiple reports. Part of what we're seeing as this emergency unfolds is that the requirements for reporting are both increasing and changing over time. And yet, most of the sources of truth, the pieces of information technology that are already available in the hospital that have the most accurate and up-to-date sense of what's going on inside the facility, aren't API enabled. In the US, we've invested literally billions of dollars in ensuring that the electronic health record systems, the EHRs, are there and ready and implementing and supporting APIs. These days, most EHRs in use in hospitals are supporting FHIR, either DSTU2 or STU3, and will be moving to FHIR R4. Yet, as we think about what's going on as patients are being treated in the ICU, the EHR is going to have a very limited sense of what's going on in the ICU. And its sense of what's going on in the ICU is often going to be hours behind events actually happening. You can imagine a nurse in an ICU or several nurses in an ICU where there's 3 patients crashing, verbal orders for patients to be intubated. And all of this activity is happening over the course of a shift. Those verbal orders aren't going to get entered into the EHR. Those orders are not going to get updated until probably the end of that shift. Because it's all going to be recorded, all the information is going to be collected, but while you've got patients who need immediate attention and care, you're going to be providing immediate attention and care, and you're going to go back and do your record keeping later. So that means that there's potentially 6, 8, even 12-hour delay before the EHR even knows that ventilators that were previously available are now in use. Whereas the ICU central monitoring solution inside the hospital is a lot closer to being the source of truth about what's going on with ventilators, because it's going to know any ventilator that's ever been connected to it. It's going to know what's going on in terms of every bed that's sending telemetry that has a patient in it. And as soon as a patient's intubated and somebody turns that ventilator on, it's going to start sending telemetry to that central monitoring solution. So the sources of truth that are close to the actual data that's needed so that we are able to understand what's going on in the crisis are not necessarily the ones that have API enabled. And as we look over time, in March, CDC released the Patient Impact and Hospital Capacity module for tracking COVID-19. Vice President Pence sent out a letter through CMS to all hospital administrators asking hospitals to report their in-hospital COVID-19 testing results to FEMA. Right? Now, if we look, the systems that are going to have that data, some of that data is going to show up in the EHR. Some of it might be in bed management systems. Some of that data is going to be in central monitoring or in asset management systems if you're trying to understand how many ventilators are available in a hospital. Others are going to be in laboratory information systems. And often well before that data ever makes it to the EHR. Right? The lab knows when the tests are ordered as they're coming in. The lab's got the results before they get to the EHR. So all of these systems that don't have APIs enabled for them, but are close to the data, aren't enabled to be able to communicate this information, even within the hospital, to hospital-based command and control centers. And then as we get further along in time and we start to understand more and more of what people need to deal with, what kinds of information that they need to deal with to address the emergency, as we realize that, well, our workforce could actually get sick, or we might need to send doctors to other facilities where there's a need for additional response because hospitals are getting overwhelmed, or we don't have enough personal protective equipment to cover the people who are providing cares in those areas where there's tremendous impact from disease. Or as we start requesting more and more data from departmental and specialty solutions or other sorts of care settings where electronic health records aren't as prevalent, then we're continuing to add more and more reporting. At this point now, we've got 1, 2, 3, 4, 5, 6, 7 different reports that need to be sent out, and probably duplicative, being sent to local public health, state public health, as well as federal agencies. And then once we've got all that set up, we've got to go back and revise those reports, because we realized that when we originally wrote the specification for one of these reports, the patient impact and hospital capacity module, the reporting data wasn't clear, so the names of fields were changed, and so that information's got to be changed and updated. So this creates a tremendous burden on providers. And we can see that there's yet going to be more change coming, because in the PPP and HCE Act, which extended the funding from the CARES Act, HHS added reporting requirements, or was given additional reporting requirements that they have to report to Congress about reporting disaggregated data by age, by gender, by race, and ethnicity within 6 months. And so hospitals are also going to have to start reporting, breaking that data that they're sending out down by those different segments. So the goal of SANER then is we want to make it simpler for these hospital-based systems that don't have API enablement to be able to communicate this data out. And so our first step in SANER was to define, well, how are we going to represent this data that's being collected? We looked at it and we said, well, these are actually measures of resilience for a healthcare system, measures of capacity for the system to be able to take on new patients, provide care for patients, measures of capacity that express how these health systems are actually treating patients. And not just patients with COVID, but also what kind of care patients are getting now as compared to what they were getting previously for non-emergent conditions. Many people have been postponing elective treatment, and even in some cases, non-elective but non-emergent treatments during the crisis. So in addition to understanding how COVID's impacting people who are infected, we also need to understand how COVID is affecting people who need health care but aren't infected. And so the idea is that we provide a way in which systems can report data very, very simply to what we call a SANER server, which is basically a fire server with a little bit of extra capability. And what that server does is it adapts the data that's given to it by these external systems to a fire measure report, is capable of aggregating data from multiple sources into a report, which you can then publish out to some sort of local public health network or internal command and control systems so that the hospital can have an understanding of what's going on inside the hospital as well. That gives that first step of being able to report the data. The next step is that within the local public health network, that local public health network can then take on the responsibility for reporting to local public health agencies, state agencies, and federal agencies so that hospitals don't have to take on the burden of collecting data and reporting data multiple times to multiple different agencies in multiple formats. Instead, that's taken on by organizations who are doing the same thing for multiple hospitals. An example of where this is being done right now is in the city of Chicago, where Rush Medical and the Chicago Public Health Department are actually requesting all hospitals within the city to report their data to the city and designate the city as being the hospital's authorized agent for reporting this data to FEMA and CDC. And so this takes that burden off those hospitals in the city, centralizes it, and allows some of that centralization and the economies of scale that can be brought to bear with that to reduce the burden on the health system and provide support for the healthcare providers who are having to care for patients in the city. In conceiving of this project, we started this project March 20th, and we had about 30 people on the initial call, which happened March 24th. As you can see, we've had a tremendous outpouring of support across many different organizations, including HL7, IHE. We've had support from the Office of the National Coordinator for Health IT and one of the projects that they're running at MITRE. And we've also had support from two other SDOs, Oasis Open and IHE USA, in doing the development. So tremendous outpouring of support in the development of this project. That project, starting on March 20th, went through the IHE Connectathon in early May, not 7 weeks after it started. And we were able to demonstrate communication of information coming from electronic health record systems like Epic and SANER, coming from ICU central monitoring systems, including those from GE Healthcare, going through infrastructure solutions created by my company, Audacious Inquiry, NextGen, Smile CDR, and others, being able to support the communication of that information to local public health. We saw demonstrated a smart on-fire app from Lantana, which was able to collect that data and put it into the format that would support reporting to CDC. Many of you who have seen so many of the maps and dashboards and everything else that have been created, for example, the Johns Hopkins dashboard with geographic information systems. So Esri happens to be one of the companies that puts those together. They're the ones that support the GIS information system behind that Johns Hopkins map that so many of us have been using during this. They were able to collect that data and build those dashboards using FHIR. And then testing. MITRE Corp has built a open source project called Inferno, that enables testing, and is able to run automated tests against a Fire client or server. And IHE USA also provided support by offering to reproduce many of the processes with some of the folks involved in IHE who are familiar with those processes in terms of verifying test results, manually validating examples, and keeping track of everything that was going on and who was testing with who. We did actually borrow from IHE one of the things that they did, which was they actually do connectathon tours. So we did virtual tours 2 days during the HL7 connectathon, in which we demonstrated multiple systems, showing the ability to both report on and visualize measures for situational awareness. And so what you're seeing on the left-hand side here is some trend reports that were put together by Esri. And if you see down at the bottom right now, I think in this diagram, they're showing data that's being reported by an Epic system, but they were also able to connect to a next-gen system, Smile CDR, Microsoft's Azure file server. So Microsoft was very involved in helping develop the test data for this, which they then populated one of their servers with. We also built a system based on the Happy JPA server. And then Symptomatic was also deploying a fire server that was able to share data. And so we were able to demonstrate the ability to produce dashboards based on any of those different systems. And you see at the sort of in the middle here is an example coming out of Symptomatic, showing a heat map in the Chicago region, and a similar heat map also coming out of the Esri solution in that same general area, reporting on deaths in the region based on the measures that were given to both those systems. So you see the ability of multiple systems to be able to report, and then multiple systems also being able to visualize based on the data. The SANER project is about measurement. We're using measure and measure report. We captured a lot of measures ourselves during Connectathon 24. During that Connectathon, we logged and tested 107 transactions using Inferno. We also manually validated 65 of those transactions to verify that they were doing what they were supposed to be doing. We build out 26 test cases. So there's 26 different tests that Inferno executes over the fire resources for both the sender and the receiver in both models of communication. There's a push model and a pull model. A push model where organizations can create and update measure reports, and a pull model where organizations can query for particular reports. During Connectathon, we had 18 issues that were identified within the specification or that needed to be addressed in the specification as the result of that Connectathon. 15 different organizations participating, including 7 sending organizations and 6 receiving organizations, as well as a number of organizations who are participating in sort of a test monitoring role, where they were providing independent third-party oversight over the testing that was going on. We have in the implementation guide as it's being developed now, produce 6 different capability statements that cover the combinations of transactions and options that are included. We actually had 3 different federal projects, an ONC project that was supporting some of the early development of the SANER IG, the MITRE Inferno work, and the ONC IHE USA collaborative, all participating and working together during Connectathon. And we also developed and published in the implementation guide a test plan. And that's going to be updated based on the results of the Connectathon testing. Project itself made huge progress in a very short period of time. So not only is it developing an implementation guide, but the project is also developing open source tools. And so there have been open source tools that have been developed by Audacious Inquiry, by Microsoft, by Symptomatic. My understanding is that I believe that NextGen Connect is going to be releasing some of the interfaces that they developed also as open source in the NextGen Connect project. Over 200 commits to the SANER IG itself. We've had 90 issues open. We built 65 example resources to support testing. We've closed more than half of the issues. We've had 10 different people who were involved as committers to the project. Can you imagine going from having nothing to going to your first Connectathon and accomplishing all of that in 7 weeks? We've had so many hours, person hours, in teleconferences that it adds up to over 5 person months, over 800 hours in teleconferences from the people who've been involved. This has been one of the fastest, going from the day the PSS was written on March 24th to TSC approval. That was 2 weeks later. And we have our first pilot in its initial stages in Maryland. So a tremendous amount of progress. We're progressing now into the next stages of development, where we're looking at simplified reporting APIs, allowing people to submit CSVs with the measure reports, and to get CSVs from measure reports, for example, as is presently being used for CDC reporting. Automating the generation of measure reports, so the measure report itself could be automated either using Firepath or CQL, clinical quality language, or other sorts of implementations. Supporting the ability to distribute and update measures in definition forms so that automation could help address some of the issues of having to change a measure or clarify a measure. As I said, we have our first pilot in initial stages, and we're looking at doing others. We're planning to participate in Connectathon 25. We've gotten TSC approval for an out-of-cycle ballot in mid-October. And we're also considering doing Connectathon in late July, early August, in support of making sure we have enough testing before we go into that out-of-cycle ballot. So in conclusion, before we get to questions, there's a lot of useful links. So the source for the SANER code for the SANER IG is actually at github.com/hl7/fire-SANER. here. We do a lot of our development of that in a fork over in the Audacious Inquiry GitHub. And that's because that's where we're doing our issue tracking, where the wiki is, where you can go to sign up to participate just by adding your name to the list here. So I've managed to get my children to contribute to this project. My daughter's doing some UX work on a UI to show how measured data can be entered. And some of the images that you see are from my eldest and his partner. Some of the graphics here that have been created for this, they've created and contributed to the project. The build is in the usual place, build.fire.org/IG/HL7/FireSANER. And you can see we've got a great deal of content here. And there's more coming, because in addition to the examples, we also have the capability statements and all of the example locations and measures are shown here. So at this point, I'd like to conclude and leave it open for questions.
Great. Thanks, Keith. We've got a question from Dave saying, I've longed for a breakout of cases and death data into 3 categories: problem cities like New York and Milan, crowded hotspots, for example, nursing homes, and everything else. Is that possible?
Okay, so if I understand the question, we'd like a breakout of data by geography, by type of facility, and was there something else, or were those the 2 key points?
Problem cities, nursing homes, and everything else.
Okay, so the idea of the SANER project is it's able to report measures from individual facilities, and included in that measure report is data that allows you to break it out by geography, allows you to break it out by type of facility. The measure report itself is basically a count of things. So it can be a count of COVID-19 deaths. And as a matter of fact, one of the example measures that we developed was based on the CDC COVID-19 module, and that includes COVID-19 related deaths. And so if you've got type of facility and location of facility, certainly you can break it down by that. And if we go back to one of the links here, you can see that there are a number of images in this diagram. This is actually that heat map on the right-hand side is a heat map of deaths based on geography in the Chicago region, and is actually 2 different applications doing exactly that. This particular map, you can actually see the 2 hot spots that we tested with. One was the state of Rhode Island, and the other was around the city of Chicago in this particular map. So this is showing the 2 hotspots. So the answer is yes, we can do that.
Great.
So what I had in mind, Keith, was so many, looking forward, and this is not from a clinical perspective, but it's from what we in the public need to be able to do going forward. Like it or not, we're reopening to various degrees. And we all have to be responsible for thinking out where are the risks going to be. And I think it's actually going to evolve into something not unlike the pollen count in the daily weather report, you know, region by region. We know that, for instance, Tulsa is booming, but in a place like the Boston area, we have like urban areas, but I'm an hour outside in New Hampshire. And so the reality, the risk reality around here in the incidence of cases and deaths is very different from what it is in Boston. And meanwhile, if you filter out nursing homes and prisons, these crowded places, my point is that the reported death and case data that we see on the news is not nearly granular enough for us to decide. Like if we want to drive on a vacation trip, I'm sure rural Michigan.
Where do you go? How do you get there? Yeah.
Well, and where do I want to go? That's what I'm seeking, and maybe SANER is the wrong place to ask. But
the challenge that you're talking about, Dave, is the issue of the state, local, and federal agencies have a responsibility to share the information that they get, which is a lot more detailed than you or I see, with the public, so that the public can do exactly that, so that the public can plan and behave responsibly and appropriately. We're not trying to solve the problem of communicating to the public. We're trying to make sure that those agencies that need to communicate with the public can get to the data that they need. And where we're at right now is that those state, local, and federal agencies who are involved in emergency response or involved in public health right now have been so focused on trying to figure out how to get the data that they need in order to respond appropriately, that they actually haven't been able to do everything that they could have been doing in terms of figuring out policy, figuring out what needs to happen, making sure supplies get where they need to go, or communicating with the public appropriately. Now, I live in Massachusetts, and we get on a daily basis, you know, a 12-page PDF report that tells me everything I need to know about what's going on in the state, and I know where to go find that. 12-page PDF is sort of a crap way to communicate to the public, to be frank about it. But it's better than what we had 2 months ago. And so there's definite progress that's being made as the data is getting where it needs to go. What we're trying to focus on is understanding that, you know, this isn't the first time this has happened. We've been talking about this since 2001 with SARS, and we've got H1N1, and H5N9, you know, and MERS, and then bird flu, and then the second round of bird flu. So, you know, this is something that we keep saying, well, the next pandemic's coming every 3 years. And we've been trying to figure out how to prepare for it. Well, now we've had our 100-year event, and now we've learned how poorly we've done over the past several decades in trying to figure out how to resolve this problem. So we're trying to figure out how to do it better. Other questions?
So I think we're at time now.
We are at time, yes.
All right, well, thank you all for coming to my Dev Day talk.
Thank you, Keith.
Thank you.
Thanks. Cheers.